you, Eddie. There you go.
Good morning, everyone. This is LaQuisha Martin-Hillian. I am your MC for today, and welcome to Community Cafe. We're going to give just a one more minute for others to log on, and then we will start. Okay, again, for those who just logged on, I am LaQuisha Martin-Hillian. I will be your MC for today. Welcome to Community Cafe. Our discussion today will be mental health awareness. We have great speakers for you today, and we also have our very own Robert Anderson, who will be assisting me with the chat. So if you have any questions or any comments, please place them in the chat for us. And we also have good morning. And we also have our very own Jerry Campbell, who will also be assisting us as well with sharing PowerPoint as well as in closing. So we're going to go ahead and get started. And we have our first speaker for today, and Dr. Walter Meters. He will be speaking about social drivers of health. Dr. Meters.
Thanks, Jerry. Well, thank you for inviting me to be here today. Let me let you know a little bit about myself. I'm an OB/GYN physician that had been in the community for over 32 years and retired about 3 years ago and came on as the medical director for Piedmont Healthcare. I'm not sure we're going to probably mesh on our title. I was told to kind of talk about the link between mental health and physical health. So social drivers may be a little bit different, but it'll be in there somewhere, hopefully. I think it's especially timely with the emergence of we're emerging from the pandemic and its devastating effects on our physical and mental health. While we were just over dealing with the specter of, severe illness and isolation and family tragedies associated with the pandemic, now we've kind of launched onto this economic instability and the impact on our financial security, what's going on with with changes in the supply chain and everything that's going on worldwide. There's just so many mental moving pieces to our overall health. It's hard to know exactly how you go about defining that. Health kind of encompasses mental, physical, spiritual, and social determinants. We tend to think about health as mostly the absence of disease, or the state of being free from illness or injury. But that's probably not telling anywhere close to the whole truth. Perhaps a better, definition would be the extent of somebody's continuing physical, emotional, and mental and social ability to be able to cope with their environment. To be quite honest, I don't think we have a real good definition of health, which makes it difficult for us to go ahead and talk about how we go about achieving that, because whichever organization you deal with, they seem to have their own special, way of defining that. Certainly being absence of any disease is difficult in trying to figure out exactly how we manage it. So perhaps absence of disease is not a way that we ought to think about health, but maybe managing disease so that it leads to a healthy life, because it's almost impossible to pursue the absence of disease in our current life. Kind of like the way it was trying to get rid of COVID. We found that is actually going to be an impossible task. We're just going to have to learn to live with it. So obviously in a small amount of time, we can only scratch the surface of what we can talk about. So let's look at a couple of myths. Jerry, the next slide. So the first myth is that mental health is generally viewed as being less important than physical health, thus falling much lower on our list of priorities. Obviously, that is really false. There's no way to tease apart those two components of our health. They're interconnected. It's not an either or phenomenon. Our mental health just impacts every aspect of our life. And unless we actually address those in a holistic manner, we're going to probably fail to be able to achieve improvement in either aspect of that. And indeed, poor mental health can actually lead to poor physical health can lead to poor mental health, as we see in chronic disease. People who are, receive the diagnosis of cancer or severe heart disease generally become depressed. Well, that's kind of like postpartum depression. It's felt to be somewhat normal unless it actually gets to the point where, it becomes prolonged, pervasive, and continuing to deepen. Mortality rates from cancer and heart disease seem to be higher in people with concurrent depression. 50 to 80% of people with mental health problems seem to have a sleep disorder, but yet only 10 to 15% of people of the general population have that sleep disorder. So we can see how mental health actually impacts physical health. So interventions can somewhat be problematic in, I guess, a primary care practice. If you've been to your primary care provider lately, they're being pushed for time. They're being pushed in what they deal with. There are many things that they're dealing with. So even though primary care providers are the portal for the entry into the system, sometimes mental health aspects tend to be lower down on the, priority totem pole, so to speak. And our model of healthcare seems to work against being able to actually help with mental health. Our healthcare system is somewhat segmented. It's not really very integrated. I guess an analogy would be kind of like a football team. If you think about a pro football team, you have various position coaches. Somebody coaches the defensive backs, somebody the linebackers, somebody the defensive line, other things, but yet they all have to work together as a team in order to accomplish a goal. But sometimes you can get so zeroed in what you're doing for your particular group that you forget that what you're doing actually impacts the other group. You can't really defend the pass if you can't rush the passer, things like that. Sometimes if you're in the offense and you're running so many plays that you get off the field, your defensive line and your defensive team is on the field longer than it should be, so it gets tired. So all of these interconnected kind of pieces have to work together. So with medical care, unfortunately though, it seems like that's where our system seems to fall apart. And I don't know really, I'm not here to kind of figure out the answer or anything, but I think integrative systems seem to work a little bit better than segmented systems. So let's go to the next slide there, Gary. I think sometimes providers seem to think that mental health problems are really uncommon. And sometimes we as patients think they're not really my problem. They're really very uncommon. But actually 70% of physician visits are for issues with a behavioral component. Patients with chronic health problems and a mental health diagnosis are 3 times to be medication non-compliant. And also as physicians, when you're dealing with someone who has a mental health diagnosis, perhaps you're more likely to prescribe or think that those symptoms are related to that diagnosis rather than investigating a new etiology and finding out that they do have a new physical condition. Next slide. Depression and anxiety obviously is a whopping problem in our population. I'm sure if when you're dealing with clients and things that you see that is a definite problem. In these particular aspects, dealing with immunity and heart health, you can see that it has a significant effect on those two parts of our health. We found that, particularly in dealing with the pandemic, that anything that weakens the immune system does make us more susceptible to complicating factors. So anything we can do to boost the immune system, it certainly helps in that aspect. And certainly as we get into our aging population, the immune system doesn't function as efficiently as it should, and anything we can do to prevent a decrease in that would certainly be effective. That risk of heart attack is 8.5 times higher 2 hours after an intense burst of anger. Well, I guess that accounts for how many heart attacks we see on I-77. So certainly, anything that we can do to decrease emotional triggers and help people deal with anger and anxiety and depression can certainly help in terms of cardiac disease. Next slide. Primary care setting is actually the portal for most people's entry into the healthcare system. Our healthcare providers are sometimes, handicapped in dealing with people with mental health disease. It takes a lot of time, and it's something that is short in their practices. Some of them may actually not have a lot of expertise in dealing with that particular problem. And as soon as somebody presents, rather than dealing with it, they may look to refer. And that's something that is problematic, I think. We have a difficult time referring in our mental health system nowadays. Particularly when I was practicing and we were dealing with people with depression and other issues, it was a little bit difficult to actually get them access to the mental health system. We either had to give them a number and ask them to call, in which case, could we go to the next slide? We find that 15 to 30% of them never even call to make an appointment, even though we provide them with all of the information necessary. So that, ends up requiring follow-up, and a lot of those patients just get lost to follow-up and never actually even make a connection with the mental health provider. So sometimes having referral systems in place that are perhaps in system works better than actually leaving it up to the patients themselves. In fact, in Piedmont Healthcare, we just recently brought on a psychiatric practice for the first time. In our 25-year history, we really had not really had that particular specialty available. It was a mature practice, and they already had their own way of dealing with their own referrals. But once they came on with us, that they got access to internal referrals. They had only been here 2 weeks, and all of a sudden they had 60 new inpatient referrals. In-network referrals, which is something they're going to have to learn to deal with, because it was a very slow process before trying to integrate those referrals into their new patient system. So we're kind of struggling to deal with that. But it did actually illuminate the fact that we really have a tremendous need in our healthcare system for that. And when we make it easier for people to gain access, people will be able to do that. Next slide, Jerry. The other thing that's been somewhat of a barrier for primary care physicians has been reimbursement. Reimbursement, I'm sure, as people who provide mental health has lagged behind reimbursement for medical, physical ailments. Although there have been new coverage policies that are actually starting to be instituted by CMS, and hopefully also through other state systems as well as insurers, that will make it much more advantageous or incentivize our providers for going ahead and providing those services. Next slide. But at its core, it seems like a collaborative care is what needs to happen. Team-based care, not just a primary care provider or other physicians just dealing with it in a segmented or isolated manner. we need to have a team approach to be able to do the best for the patients that actually would benefit most from mental health referral and also dealing with their chronic disease. It's difficult in our system that we have at the present time. Sometimes a big hospital system, even though it's sometimes is, I guess, problematic from access, they have the resources and the system being able to actually integrate that care. And in fact, my son works down at Atrium Health, and he is the director of operations for the psychosocial management of the Levine Cancer Center. So the Levine Cancer Center in that particular access has realized that psychological care for their cancer patients is vital for their recovery and the way that they access their care. So they've actually developed a whole system to be able to deal with that. And that is just been invaluable for those patients in going ahead and being able to combat that particular illness, because we know how devastating that is to people's mental health. But it's problematic in a small community which has limited resources and a non-integrated system. So we have to kind of, going forward, hopefully we can find a way to go ahead and become more of a team approach. And I think I'm on my last slide. Next slide. So what can we do? Obviously, these are some easy things that we all know kind of helps out with our mental health and also our physical health. It is funny that these are things that we probably know intuitively that probably work, but as I guess healthcare and mental health providers, we don't really want to institute those until we have studies that prove they work. So it is funny that periodically you'll see things come out and say, laughter really does improve people's mental ability and ability to fight chronic illness. We know that basically humor and laughter is good for the soul. We know that a nutritious and balanced diet is possible. Getting outside is something that did combat depression and illness, particularly during this most recent pandemic. And of course, a support system of friends, family, as well as members of your social organization and culture. One thing I did leave off was that we probably need to be a bit more concerning with the use of social media and our smartphones, because certainly significant use or overzealous use of those particular things tend to not always be good for our health. They tend to, there's a lot of negativity on that particular aspect. And so sometimes we see that they are actually deleterious to our good mental health. I don't know if this was what you all were really looking for, but this is, I think I've run to the end of my time.
Thank you, Dr. Meters. Are there any questions that anyone may have for Dr. Meters at this time? Well, I would say, Dr. Meters, for me, I worked at Atrium Health for 13 years as a social worker. And we did do a brief study with diabetes, individuals who were diagnosed with diabetes. And we had a team that was based on a social worker, a resident, an attending, but we also included a therapist there as well. And they were able to link them to the services that they needed. And it did place a tremendous impact on their health. So I would definitely agree with what you stated there earlier.
Yeah, I think someone did make an interesting point on the chat box about primary care practices being the gateways into the mental health system. And statistically, 45% of people who died from suicide had seen their primary care providers within a month of their death. I think that just goes ahead and just illustrates the fact that sometimes we need to help educate our primary care providers in looking for signs and also be sensitive to those indicators, because sometimes it's very difficult in a 10-minute visit to pick up on things like that.
That is true. Yes, sir. Anyone else?
So it looks like we do have a question in the chat for Dr. Meters. Do you have any suggestions on how the healthcare providers, given their limits in time and need for documentation, can better assess mental health needs in routine appointments?
Well, the thing that we're actually looking into now is that actually we're integrating a screening protocols into those healthcare appointments. That's one thing that value-based care has started to actually help out with, is that, you know, instead of actually people, providers getting reimbursed on a fee-for-service environment, value-based care is actually going ahead and, well, basically, the healthcare system then is responsible for the total cost of care. So it actually will incentivize physicians to look at all of the aspects of the care in, say, an annual wellness visit, where they come for that particular visit and access their mental health as well. So they're incentivized to go ahead and do mental health screening, depression screening, things like that, and integrated as part of their, you know, physical evaluation as well. I think one of the things that we've tried to, and again, that's obviously very individual with every primary care provider or even other physician who actually sees patients, is you just have to be sensitive during your interview process and talking to the patient, and pick up on those signals and realize that if you do see those signals, sometimes you have to set aside your documentation and set aside your time and to go ahead and deal with those processes and make sure that you do deal with that and just not move on to the next patient. It is a difficult situation trying to balance those things, but we also, in all of our meetings, we do go ahead and try to emphasize that treat everybody as an individual and be very sensitive to the signals, perhaps intangible, that they're giving you during that interview process, while going ahead and applying good screening protocols to kind of help delineate that.
And one more question, Dr. Meters. I believe you kind of answered this, but it says, if you have a person that you believe has some mental health issues going on, how do you get them to see someone?
That is a difficult process in our environment, isn't it? Typically, what I've tried to do is I have a ready resource guide of mental health facilities that are willing to take patients. And sometimes you have to kind of, unfortunately, grade that by their insurer status. Some mental health facilities will take commercial only. Some are actually going ahead and available for Medicare and available for Medicaid. So I encourage all of our providers to actually have that in ready access so that you have a list to be able to call. And I think one of the things we could do from a community is actually maybe have a better listing of all of those things available so that we can continually update that as they become available. I'm not aware of a central, I guess, access point where we can really know all of the possible resources that are available in our community. It's a kind of behooves the provider or somebody to go ahead and just do that on their own. That might be something we could kind of work on.
Dr. Meters, I have a quick question for you. And it's a little bit of an observation too. Last year, at my son just turned 1, so I was pregnant the year before. And when I initially did intake at my OBGYN, there were like standardized screening and questionnaires, and a lot of it was asking about trauma. And what I observed during this was the questions were part of an intake process, but they weren't very trauma informed. So when I was being asked about any kind of trauma in my past or anything like that, it was basically just checking a box. And my observation was that maybe if we're looking to reduce the stigma or to create a psychologically safe space for people to be able to disclose, then what are some ideas, or what are your thoughts on doing some trauma-informed training with our intake nurses or staff members that are asking these questions?
I think that would be very valuable, because I agree with you. Most of the time when you are actually incorporating those questionnaires, they're just because either a society or it's a checklist. It's a box that I have to ask these questions in order to actually just move on to the next section, so to speak. It's not really very informative. The practice themselves probably did not even formulate the questions. They just got them from another list, like either the American College of OBGYN or Family Practice Society, things like that. So I think you have to have the intake person and the provider to be genuinely interested in wanting to actually deal with those problems should they unearth them, rather than just being something that's a matter of routine, making it part of your chart. Yeah, I think that would be great to go ahead and just offer that training for them. Yes.
And we have one last question for Dr. Meters before he has to jump off. Do you agree with the PCP handling medication management for mental health like anxiety and depression, or would referrals to counseling and psychiatry be better suited to get the root of the symptoms?
Well, you're going to get me in trouble here. I think that basically, there are primary care providers who are very interested and are skilled in medication management, and then there are others who basically are less skilled, let's say. Certainly, they should be. You would tend to think that referral for counseling and use of mental health services would be advantageous. But as we can see, that if the primary care do not handle some of this, that very, very quickly those resources will be overwhelmed. There is a medications for anxiety and depression. There are a huge amount of people that take those type of medications and need monitoring for those. And I'm not sure that the mental health resources are actually, there's enough of those in place to actually manage all of those. I think we could do a better job with our primary care providers in providing them education in the appropriate use of those medications, and trying to figure out, not using the best and latest, greatest antidepressant or the best and greatest anti-anxiety, and trying to actually tease out exactly what is the diagnosis you're trying to treat, rather than just using a medication that has broad indications that can treat everything, so to speak, and tailoring it to the patient. That's something we're definitely looking forward to doing with Piedmont Healthcare, is actually using our primary care provider monthly meetings to help educate our providers. Since we've actually gotten our psychiatric practice on board, that's one of the things that they've actually wanted to actually bring to those meetings, is actually go ahead and provide some in-service for our providers to go ahead about the appropriate use of the use of anti-anxiety and antidepressant drugs. It'd be better efficient for those. So that's something we're hoping that is certainly in our group, that we're hopefully able to improve going forward.
Okay, Dr. Meadys, we do know that you have to jump off, so we thank you so very much in advance for coming and sharing your information. If there is any additional questions for Dr. Meadys, we'll be sure to just leave that in the chat, and we can possibly see if we can.
Feel free to send them by email. I'll be glad to respond.
Thank you so much, sir.
All right, thank you so much. Bye.
Bye-bye. And now we have Mr. Delton Russell, who will be speaking with us in regards to peer support. Delton.
Hey folks, thanks for the opportunity to be here today. If you've met me before, you know that this is one of my most favorite subjects to talk about for a lot of reasons, one of which is I'm a peer support specialist myself. What that means, peer support specialist is a person that's in recovery from either substance use or mental health issues, most likely both. But either way, it's a person that's in long-term recovery, sustained recovery that works to utilize their lived experience to help other people find their own pathway to recovery. An example of what that looks like. So, while I'm not a doctor and I can't advise a person on medications, what I can say is if I'm working with a peer and they're talking with me about their medications, what I can share with them is, when I first started taking medications, I found that my medications were working a little bit. But when I started implementing changes into my day-to-day life, like getting adequate levels of exercise, eating a healthy diet, writing gratitude lists in the morning, meditation, things like that, I began to find that the medications that I were taking worked far more efficiently and more effectively than they did when I was just taking those medications by themselves. So what I'm doing first and foremost there is I'm delivering hope that things can be better because things got better for me. So it's possible that it can be better for them. Right. And then in addition to that, I'm giving some education about different things that we can do. I'm role modeling personal responsibility. Right. I didn't look to somebody else to do the work for me. I learned how to do the work myself. And then, I'm advocating for myself. And I'm offering support and role modeling how I've gotten support in my recovery. And those are the 5 key concepts of wellness based on the wellness recovery action planning, being that of hope, personal responsibility, education, self-advocacy, and support. And those are things that I'm going to be helping people that I'm working with out in the community implement into their day-to-day, so to speak. But most importantly, though, it's important to understand that the peer support specialist is a liaison between the client and the clinician. I understand where the client's coming from. I understand where the clinician's coming from, and I can help bridge that gap. And one of the biggest values that comes out of that peer support in terms of being that liaison is I can potentially increase the likelihood of developing a better therapeutic alliance. I can really help the client see and understand what it is that the clinician's saying to them. Therefore, there's a better connection. A lot of times we think that we're speaking the same language, but we're actually speaking different languages, right? If you've ever met somebody that's from a regional an area regionally that's different from the area that you grew up in, you might hear somebody call a water hose a hose pipe, and you're like, what exactly is a hose pipe? That's a completely different thing. You have to use some context clues to figure out what it is they're talking about. Well, when it comes to a clinician, especially somebody that's maybe or earlier on, maybe a little green, that hasn't had a whole lot of experience just yet to really understand those things, having that peer support specialist can be really important. So other things that we want to talk about, Dr. Meters was talking about connecting with folks, and how we as a system, we sometimes struggle with that. And, that's because we've historically talked a lot about the recovery model, but we've really acted more in the medical model. And the medical model tends to be a little more, what's the word I'm looking for? It tends to be a little more sterile. It's just like, you do this, you get that, like you break an arm, you get the arm reset and you leave. And mental illness is often far more complicated than that, especially, once we put in complicating factors like high levels of trauma. But thankfully, due to Medicaid transformation, we're starting to implement the value of recovery model into how we're providing services, and also in making those services more wraparound. So how do you find a PSS? If you're an organization looking to hire a peer support specialist, a place that I would look at would be starting with the UNC Chapel Hill Springboard website. Robert will put that in the chat for you. You can reach out to them, and they can help you figure out where you can find a peer support specialist, somebody that's already certified, somebody that's taken the training, that's gotten approved by the state, that's ready to go. Or if you have somebody in the community that you're like, hey, you know what, I think that you would make a great peer support specialist, would really love to hire you, but we got to get you trained first, right? So, that would be a good place to refer that person to, so they can find a trainer in the community, and also they can figure out the steps that they need to take to be able to get certified. That said, one thing that I meant to mention earlier that I forgot, Medicaid currently is peer support is currently a Medicaid only billable service. So it does work really, really, really well for substance use disorders. In fact, if you look at mutual aid fellowships like AA or NA or Celebrate Recovery, Smart Recovery, whatever, all those, the key factor in all those being effective is peer support, because it's all people with lived experience helping other people find their own pathway, right? But that said, it's important to note that the state has not passed Medicaid to be for all folks. It's only for folks that typically have severe persistent mental illness, or people that have some debilitating disabilities. So people with substance use disorders don't fall into that category. So not yet, at least. Hopefully we'll be able to address that at some point in time and push that forward. But all the same, and as of now, it's definitely a Medicaid only billable service. So your people that are going to be applicable for that, like I said, most likely in relationship to mental health, are going to be your people with severe persistent mental illness. Occasionally, we do find people with substance use disorders that have Medicaid, but it's not as common as we'd like for it to be. Anyways, so other places where peer support is available, you can, a wonderful place to learn about peer support is Promise Resource Network. Shireen runs a wonderful program in Charlotte. You could reach out to her. I know her personally. She is very, very kind and will most happily take time to speak with you. Also, she can connect you to a mountain of resources anywhere within the state. Another place to find peer support is going to be Anna Rossi Place. I don't know if any of you are familiar with that, but it's a psychosocial rehabilitation center here in Cabarrus County. It's in downtown Concord, across the street from the courthouse. And it's a place where people with severe persistent mental illness can go and be around other people that are in a similar situation. There's a lot of peer support happening there. Not only do they have peer support on staff, but they also have peer support implemented within the model of how that program works. And then, of course, there's always NAMI, the National Alliance of Mental Illness. One of the most valuable pieces from NAMI, and I speak from personal experience, having utilized NAMI's support groups in the past. One of the most valuable pieces of NAMI is having that peer-to-peer connection. Again, being around other people that have lived experience that can help me find my own pathway to recovery. Also, truth be told, being around people that have lived experience sometimes helps me to not feel damaged, helps me feel normal, because I'm around other people that have shared experiences that I have. That's why, if you are a cancer survivor and you meet another person that's also a cancer survivor, there's that connection there, Now, that said, we want to be careful. We don't want a trauma bond, but all the same, it's a really good place for us to meet other people and develop natural supports, not just paid peer supports, but also natural supports that are peer related. So also something that Dr. Meters touched on that I wanted to highlight, he talked about social media. And social media is a really interesting place because there's a lot of really good peer connection in social media. There really is. But, we also have to be careful, about that, because never have we been connected more and also disconnected more at the same time. It's a very surface level interaction, and as a byproduct of that, sometimes we have a tendency to just kind of zone out and you get that dopamine release in our brain versus actually contending with the issues that are weighing on us. And that's where finding peer support within social media can be a really helpful experience. So if you just, not to state the obvious, but if we look at hashtags, there's a lot of really good hashtags out there. Obviously, peer support, NAMI NC is a good hashtag. Recovery is a good hashtag. Any of those things, those are really good places for us to start. Anyways, so that's kind of a brief overview of peer support and the implementation of peer support in our area. Does anybody have any questions by chance? You can ask me anything that you like. I'm very open, so don't worry about offending me or asking me an uncomfortable question.
Delton, I have a question in regards to the duration of peer support. Is there like a limit or a time limit in regards to how long a person can be linked or receive the services?
Oh, absolutely. I mean, it's a billable service. So, people are only going to be able to utilize that service for it like any other billable service. They're not indefinite. That said, it's based on the person as to how long they get approved for. But typically speaking, they get approved for a set amount of hours a week. And that's not, I've personally never seen anybody's treatment authorization request get denied for peer support. And I've been a peer support specialist since 2010. I've worked in the MCO structure since 2012. I've never seen anybody get denied. Not saying it's not possible, but I'm just saying I haven't seen it.
Okay. Thank you.
Mm-hmm.
Does anyone else have any questions?
Mike Wall has his hand up. Go ahead and ask your question, Mike.
Thank you. I appreciate it. In regards to connecting people in recovery to recovery supports in the community, community-based recovery supports, is that a specific service or a specific activity involved in the limited number of peer support units of service? Thanks.
Mike, to make sure I'm understanding your question correctly, are you asking if it's within the peer support scope of practice to connect a peer to peer recovery support services in the community? Yeah. Okay. So absolutely. That is very much. So as a peer support specialist, we're not a therapist, but there's therapeutic value in what we provide, right? We're not case manager, but we do connect people to resources in the community. We kind of skirt a lot of different areas, but being knowledgeable about your community and being knowledgeable about the resources in your community is absolutely an imperative, incredibly important piece of being an effective peer support specialist. Because we are a paid support as a peer support. And we kind of skirt a kind of a weird line there. We have healthy boundaries. We have our ethics we have to maintain, so on and so forth. But we do skirt kind of a line about being a friend, but also being a paid support. But ultimately, one of my primary goals has always been to connect people to resources in the community to help them develop their own natural supports. Sometimes that looks like, referring somebody to Anarossi Place, or sometimes that looks like me going to an AA meeting with that person. Now I'm a person in long-term recovery from substance use disorders, so that's appropriate. That also looks like me going to a Celebrate Recovery meeting with that person, or that looks like me saying like, hey, what would you enjoy to do like volunteer wise, and they're like, well, I have a nephew that lives with Down syndrome, and I'm like, okay, so what would you think about volunteering for the Special Olympics? And they're like, yeah, no, I could do that. So I'm gonna go with them and help them sign up and register and all that stuff so that they can volunteer at Special Olympics. And the thing is if I'm volunteering there and you're volunteering there, then chances are we might actually have something in common, right? So it creates an opportunity for that peer to meet other people that they might have things in common with in more unconventional ways, and also gets them out of the house, gets them physical, gets them engaged, gets them active, helps them do things that they can feel good about at the end of the day. Hope that answered your question, Mike.
Yes, it did. Thank you.
Yep.
Okay. Well, Delton, we want to say thank you so much in advance. If you have any additional questions for Delton, we will, if it's okay, place your information in the chat and we can get that to you directly. Our next speaker is our very own Dr. Katie Barnardo, who will be speaking to us about how to access resources.
So to start with, I want to give you all a little bit of my background. And I started off working in a hospital as a CNA on a psych floor. And I had a bachelor's degree in psychology. And I knew at that point that if I wanted to move forward with my career, I'd either have to become a doctor or a nurse or go back for something else for a master's degree. And so I decided to go back for a master's in healthcare administration because I wanted to have an impact on the system and on policy, because the people that we were seeing coming into the hospital, they didn't have advocates. They didn't have anybody in the hospital advocating for them on the outside. They didn't have anybody on the outside really advocating for them at a systems level. So in my mind back then, that was the way to go. And when I first started with school, I started volunteering with the Mental Health Association. And that really changed my perspective on community work and community services and what is happening in the community. Because at that point, I'd been living inside of a box. I'd been locked on a psych ward for 6 years. So I didn't necessarily have the perspective of what people were experiencing in the community. And one of the first interactions that I had working with and volunteering for MHA was with partners and with the community collaboratives. And a phrase that I learned back then that has stuck with me all the way up until now is our no wrong door policy, that you can go to any one of us in the field at Mental Health Association at the time or at partners or any of the providers that we contract with or work with, and we would help you. If we didn't have the answer, we would help you find someone that has the answer. And that's been a wonderful philosophy that we've lived and that Partners lives. So any one of us that is on this call, if you were to reach out with a need, I know Thomasina put in there how to connect someone with resources that is experiencing some mental health challenges. We're proud to say that any one of us will walk you through the system, get you connected with whoever you need to. We have a wonderful access to care line. And then there are also a lot of nonprofits in our individual communities, like mental health associations. United Ways are really active. There's NAMI that is up and going strong in a lot of our counties. And all of these organizations are advocacy organizations that can, I know from personal experience, the NAMI director in some of my counties will sit with you in the emergency department if that's what's needed. So they're very passionate advocates that want to get people connected with resources. So I want to put that out there to you all on this call because it's not just about mental health anymore. It's not just about substance use anymore. It's about whole person wellness. And what that means is that your mental health, your substance use, or you have a substance use diagnosis or intellectual and developmental disability, often it comes along with some physical health challenges or vice versa. And so our philosophy as we're going through Medicaid transformation will have to be not only an open door for mental health, but also for physical health. So all of us that have been laser focused on behavioral health, working for partners or a provider, we're having to shift our perspective too into encompassing that whole person wellness. So for us, it's looking at it from the other angle. And I know there was a comment in the chat box about why haven't we been able to implement integrated care? And that's something that the state of North Carolina is really pushing with Medicaid transformation. But it's a complete culture shift, both for us in behavioral health services and for those that are in physical health and pharmacy. All of us are having to change the way that we're incorporating and providing services that make up a person's complete wellness, whether that's physical health or behavioral health. And the state of things with Medicaid transformation, we should be getting outcomes in the next couple of months for how that has gone with standard plans going live, because coming up as of July 1st, we'll have a year into Medicaid transformation. And then our tailored plans, which are our partners, LME MCOs, they will be going live in December. So we'll get a snapshot of what the outcomes are for that and what's working and what we need to go back and reevaluate. But keep in mind the no wrong door angle of, if you need help, feel free to reach out to anyone at Partners. We'll be able to help you out. Your nonprofit resources, your community resources. And I'll agree with what was said before about social media and looking at those hashtags and looking at the initiatives that are going on online. And there's a lot of new ways to access services like texting, chatting, and Instagram, Facebook. There's a lot of ways to access services now. And the key issue, I think, enough to where people are comfortable reaching out for help. They have to be comfortable reaching out and then know where to reach out. And we've worked really hard in the community to both reduce the stigma and to make it known where people can go for help physically, where they can go for help over the internet, or picking up the phone and calling or texting. And I'm kind of rambling a little bit, so I'll stop and see if you guys have any questions. And also, I will give this to you all. Jeannie and her training crew are wonderful, wonderful ways for you to incorporate resources and information into your organizations, whether that organization is a healthcare provider, a mental health provider, for-profit, nonprofit. It's a way to get your staff or the people you're serving some information about behavioral health and also connecting them to resources. And it's free.
Any questions? I have one. Do you find that with the increase in the need, do you find that there with linking individuals to the services, that there are wait lists or anything in that regard?
It depends. We're experiencing across the state a shortage in placements for youth and adolescents. So we're seeing a lot of wait times there. And this is a good example of why preventative care and primary care is really important, because in mental health, or the Mental Health Association actually coined this term before stage 4. So in mental health, we are the only area of healthcare that waits until stage 4 for people to access services. So if we were looking at this in terms of like a cancer or a physical health diagnosis, if we got to stage 4, we wouldn't have a lot of options left. And so that's what's happening with people in the emergency departments and needing those acute placements, is that we waited until stage 4 to access services or to provide services. And a good way for us to be able to intervene there or prevent that is really getting people connected before they get to that point of crisis.
Thank you for that. Does anyone else have any questions or comment? Okay. Well, I want to say thank you in advance to our speakers today. It was an array of knowledge and information. And I will now turn this over to our very own Jerry Campbell.
First, thank you to our three speakers today. And if there's questions for them, I think their email contacts have been put in the chat box, as Lakeisha noted. So I wanted to give you an update for next month. Next month, we'll be continuing this conversation to a degree, talking about self-help and what we can do for ourselves and how to help others as well in our different communities. I do ask, though, look around the room, see who's here and see who's not here. And, you know, my challenge to each of you would be to invite at least one person to be a part of these and ask questions. Think about who's not here that could have benefited from any of the three people that spoke today from any angle. Clearly, with their presentations, there's a lot of people that need to hear this information and could benefit. So these are open to the general public. Anybody can attend. There's no cost. We try to get in and out in an hour. That way we're respectful of your time. So June 22nd at 10 a.m. Wednesday morning. It's the fourth Wednesday of each month. Please join us. You can go to our website and go to our calendar, and it has that. Robert, can you put the link to the calendar in the chat box real quick? Awesome. So it'll be there. Just click on it and you can go ahead and register. Again, the topic will be self-help for you and those around you, and looking at not just yourself, but how to support others. Thank you very much.